running, hustling to make the save. This young fella stepped out in front of him. Coach goes, oh, yeah, I recognize that jersey. A little pat on the head, a high five. Just a great moment. And part of what has been a great season thus far for Uno. And you love this tonight. He has not had to come out and be Superman. And that's what's really started to unfold over the last several games. Jalen Green looking on there, but 6 points in his 10 minutes, but it's been Brooks and Allen setting the tone.
Well, we already know Jalen Green finally gets himself right. He just needs to take his time and do it. We already know what he can do. Yeah, he gave us a nice taste of what he can do.
Can't get much of a better appetizer. Here is McConnell trying to shake free the pesky defense of Royce O'Neal. And then Hunt unable to control it. Suns basketball. Gillespie. Connell trying to stay attached to him. Off to Allen. No hesitation. Working baseline. Bounce pass feed. Gillespie sets it on the court. Splash down.
He didn't stay up toward the top. He gave his teammate a sight of him right there on that baseline. A target. Got to move below the ball.
38% from beyond the arc of the season. Monte Morris with the ball fake. Trying to work inside. Driving on a baseline. Jump reverse. Won't go. The Robinson Earl. So back come the Suns. Allen gets a screen. Nothing inside.
Hello, thank you so much.
Gillespie working on Robinson Earl. Tagged up there. Lost the rock. Turnover Phoenix. Here comes McConnell. Drops it off to Siakam.
I hope you subscribe
Bumped and fouled. Sent to the floor.
and like the live.
Royce O'Neal and Siakam.
I'm hoping to finish this work tonight.
Look out. Siakam.
I've been quite busy at work lately.
And look, Royce doesn't run.
Thank you so much.
So whatever Siakam says, Royce is not a guy that typically has a quick trigger. So some magic words were said by Pascal Siakam. And so the second double technical of the night here. And Rick Carlisle is clear down on the Suns' end of the floor. As Natalie Saga reminding him, is like, your seat is down there.
When I'm done with the shit, then I just add a few details to the face. And then I can call it done. With the dress I'm in.
Collision between O'Neal, who looked like he kind of got bumped into Siakam, took exception to that.
I'm currently watching the Suns versus Pacers. Who else is watching?
Pascal Siakam in his 10th season, averaging almost 25 points per game. 27 in their loss Tuesday against the Jazz. River back on the floor, working against Monte Morris. Good one, steps inside, high off the window. How about that? Oh no, this is a good shot from Jordan Goodwin.
This is too small. I'll tell you about that is too small. He looked real small. Jeez, he looked small.
Jordan Goodwin has got some.
Now I've got to sharpen my pencil. So give me a second.
As he shares a few comments with TJ McConnell. Time out on the floor.
So difficult sharpening charcoal pencils.
No, it's time for the Ticketmaster drop. That's right, look up. We're dropping t-shirts right now.
Oh, what's your medium?
They're coming down. Look up, look up.
What medium do you usually use?
Keep it going, y'all.
What's your favorite medium?
So let's begin with the pediatric eye exam and some tips. Now, in medicine, you guys have heard of universal precautions. It's important to be properly equipped for any procedure. Sterile technique needs to be sterile. Now with kids, we have to do a couple of extra things. And one of those things is you have to protect yourself. Now that is a welding apron. It's kick-proof in the lower regions. Some welding gloves, and of course children can spit. And so we have to put on our proper apparel. Now, I tried to get a child from one of our employees, despite my attempt to institute the Tomoka Tots program, was not able to do so. And so I had to bring in a, well, you'll see, basically a stump baby. So this is going to be our child for all of these exam techniques, and let's see how this works out. Now, one of the problems, of course, with children is that it's not the same as the adult exam. Even something as simple as checking vision in a child can be very challenging. We just can't use the same techniques. Anyway, moving on. In the adult, it's very obvious how we check vision. We start off with the basic Snellen acuity, basically to 20/20, 2400, etc., etc. And if that doesn't work, we go to the count fingers. And if they can't see even that well, we start talking about hand motion. Can they see your hand moving? And if they can't even see that well, we're talking, can they see light perception or not? And of course, there are some other levels. Projection, can they see where your hand is moving, up and down, left and right, or is the light coming from above, below? This gives us a little bit better sense. Now with children, it's quite a bit different. With kids, it's not so much how well they can see, it's how well they can communicate. So you may start with Snellen acuity, be it letters, numbers, animals. Then you go on to fix and follow, and finally blink to light, whether they blink to light. So I'm not going to tell you how to do a Snellen acuity in a child, you're probably better at it than I am, but I will show you this. I think it's very interesting. This is the child near card, and it always amuses me when I see these things because it's so antiquated. Like, what exactly is that telephone there? A child has never seen a rotary telephone, have they? And I think that must be some Vietnam-era Jeep as a car, and yet no children has ever seen that before. And so, and of course there's a horse, and a lot of kids haven't seen that either. So, anyway, moving on. Fix and follow, we all know how to do that. Basically, you grab an object in your clinic, you move it around, try to do one eye at a time, and see if they can look at the thing. Now, an eye drop bottle is pretty boring, so cell phones are always good, but don't let the child grab your phone because they will, as you mothers know more than anyone. Now, kids are quick. They're fast. They pick up things. They look at things very fast. But the problem with kids is they also get very bored very quickly, easily distractible. And so the key in the office is to have as many objects that you can show these kids at a time. Because there's a rule, and that rule is the one object, one look rule. You show an object, they'll look at it, and they'll do it for 1 second, and then they'll become distracted with something else. And so, anyway, if this video seems silly, I did it all in one take, so bear with me. But the key is to have as many things as possible. Now, I don't have kids, so I had to go to Babies R Us and pick out as many things that looked distracting to me as possible. That's more her. Okay, it's Halloween. If a kid won't look at this, there's something wrong with them. And finally, all children like
Oh, okay. I haven't done watercolor yet.
Propane torch. It's hot. Don't touch. And when we're looking at kids, we're not even looking so much for how well they can see when they fix and follow. We're looking for symmetry. And if you have a child and you cover one eye and they do fine, but you cover another eye and they freak out, maybe it's because they've got one eye working. Maybe by covering their only seeing eye, they're reacting to this. And so this child might have some type of visual problem, amblyopia. Symmetry is what we're looking for. The Snellen chart, if I got a 6-year-old who can't see better in 20/40, I'm not worried as long as both eyes are seeing about the same. It's when one eye sees much better than the other, that's when we worry with children. Now, retinoscopy is, of course, the technique we use to figure out what the prescription is. We use this in children, preverbal children, and adults who can't read back to us. And as you know, the idea is that you hold
All
up
right,
shiny
all right.
eyes,
Thank you so
look at the
much.
retinal
Have a good
reflex,
night.
and hold up different lenses in order to figure out the right prescription. Now, we're going to go over that more in the following lecture. With children, I always use a loose lens. Now, we have retinoscopy bars that have all these lenses in it, but kids will grab that thing, so you just can't use it. You have to use the loose lenses. It's almost invisible, the clear ones, so they don't know what you're doing. It's much less distracting. Now, when checking pupils, kids are always scared of the light because it doesn't look like a flashlight. So what I like to do is shine it in my own eyes, shine it in their parents, hold it up to their fingers. That makes their finger glow red. They seem to really like that. Then, only then do I shine it into their eyes and check for their pupillary response. So, a little tip, a little trick. Now, when you're checking pressure in a kid, tonopen is obviously not going to work. Is seeing if they're soft to palpation. Now, if a child lets you do this with their eyes open, there may be something else wrong. And the whole idea here is, you can only get so much pressure in a child. And so what we do is we look for, that's how I put dilating drops in, by the way. No, I'm kidding. If you see a kid and you're thinking glaucoma, well, you have to start thinking, what could manifest as glaucoma? Because you're obviously not going to take every child to the operating room and do an exam under anesthesia. And so there are certain signs that we look for. Now, one of them is tearing, but as you can see, it's so non-specific, all babies seem to cry. Another one, of course, is cloudy cornea. So the pressure is high in the eye, that pressure will push water into the cornea and cause a steamy cornea. Now, if you see a kid that has a very large eye, such as this eye right here, while the kid may look beautiful, big giant eyes, this may be a scary sign because if a kid has a very large eyes, they may have congenital glaucoma. High pressure inside the eye over time stretches the eye. Kids have very elastic scleral walls, and you can really expand, especially the cornea. So if you see a giant cornea in a child, you have to start thinking, maybe that's congenital glaucoma. Parents would love it. The kid looks gorgeous, but they've got a problem. This is a picture. The one on the left is a child with congenital glaucoma with some cupping. Not bad, but some cupping there. The picture on the right is the same child a couple years later after successful treatment for glaucoma. Now, it's kind of interesting because here you can see that the cup-to-disc ratio has actually improved over time. This is the one case where a cup-to-disc might improve, which is pretty neat. And the reason why is because kids have very elastic eyes. As the pressure goes down, this is one of the cases where things shrink again and you can actually make the cup-to-disc a little bit better. The damage is still there. Nerves die, but it looks better with time. Now, when checking confrontational fields, kids will cheat like anything. So what I do is I'll hold two hands up, and they don't know which one to look for, and I'll switch fingers. That's for the older kids. A younger kid, you may have to distract them with an object, and then while they're looking at that object, bring in another object to the side and see if they notice it coming out the side. So, confrontational fields, best you can do. One thing that's very useful when looking at kids, eye movements in general, is stickers, because you can stick a sticker on your nose, it frees up your hand. Child's not used to that. They look at the sticker, and you can check for tropias, phoreas, eye muscle stuff. Moving on. If you're going to use stickers, though, you need to know your modern cartoon characters. Which one was that? You all know these? Okay, and that last one? Dora. What's this one? I think it's Boots. Is Boots the name? Yeah. From the barrio. That's right. Sesame Street. And exactly. You got to know these things if you're going to talk to children. One nice thing about stickers is it has an exfoliating effect on the nose. Really clears the pores. And you can also attach them to children, but preferably not the same sticker. Moms get a little nervous about that. Now, I think here what I'm going to do is check for eye alignments. And this is a test called the Hirschberg test. And the idea is the corneal light reflex test. You're looking at how the corneal reflex, the light bouncing off the surface of the eye, looks in relationship to the pupil underneath. And as you can see here, that light reflex is a little medial. It's a little bit towards the inside. This doll is exotropic. The eyes are a little wall-eyed. So it's the Hirschberg. And there's a rule for every millimeter off of the pupil that light reflection translates into approximately 15 diopters of atropia. It's just a general guideline, but if you have a kid, it's often hard to do a cross-cover test, and that may be the only way you can do it. This is called a Krimsky test. It's sort of the opposite. Basically, you hold a prism in front to neutralize or fix that pupil reflex. See, it's moving over to a more normal position, and basically you hold up different prisms until you get it back to normal, and you figure it out that way. I don't use the Krimsky that often because most kids don't like having things in front of their eye and they won't sit still, but it's very useful. But in general with children, I always use loose prisms. There are prism bars, and some people just love these, especially adults for business doctors, but I find them so difficult to use. I pretty much use loose lenses for adults and children. It doesn't slow me down that much. Checking a kid at the slit lamp can be challenging, and if they're too small, you just can't do it. If they're old enough, you can get them on the thing, go for it. One nice thing about kids is that if they have a problem, they usually only have one thing wrong with them. It's very rare to have multiple problems in children. Adults, we have multi-systemic issues, but with kids, usually one thing at a time. So get a fast look as best you can. If the kid's too young, you may not be able to use the slit lamp. If they're young enough, you may be able to put an eyelid speculum in, which is a little torture device. But you know what? It's better to see his eye, make sure the kid's not going blind, and put him through some discomfort. And this usually upsets mothers more than anyone. And then fathers are completely useless when it comes to holding a child. So just remember that. The final point I'll make as far as the kid exam is that when you look at the retina, if you can get the child to fall asleep, sneak in, turn your light beam as low as you can. You might have to turn the room lights completely low. The less light going into the eye, the less the child will be annoyed. Very, very gently open the eyelid and try to sneak in there. Because if you can't do it asleep, you're going to have to put that lid speculum in, and it's a big pain in the butt for everyone. So, I hope you found this useful. Some basic pediatric tips. And I appreciate your time. And let's take a little break. What time is it? It's about 8:20. We're going to take a 5-minute break, and then we're going to come back and we're going to learn how to do retinoscopy. Thank you. Amblyopia. Amblyopia is very common. I've certainly seen studies saying that maybe up to 2% of the population has some degree of amblyopia. All amblyopia is vision loss without obvious organic cause. Here's the theory behind it.
Oh, come on.
Kids, their brains are still forming until about age 6 or 7. You know,
Right now. It's a lot of advantages for us. Our cutting opens up a lot, and then when we're in transition, our gates running to the middle of the court creates a lot of spacing. We also play fast, so most of the defense is on their toes as well.
Yeah, and look, we said it going into last night's game, and based on their shooting last night, they're now tops in the league in terms of what you call and consider wide open threes. 25 attempts throughout the course of the game. They average about 42, and they knock down 50% of them.
Yeah. Well, you open like the Suns, and then you gotta knock them down.
Brooks on the screen, high arching three this time as Siakam gave chase.
Yeah, they should have given Siakam a fake, and maybe they're drawing the foul.
Neesmith trailing on the play.
Too strong with that one. That's a good rebound there. Also, he's running past the ball and was able to control it.
Now, this has been one of Oso's better halves of the season thus far. Booker puts it on the spin cycle. Pops it up and in.
Robinson Earl, he's getting worked over, man. That's all. I mean, from Dylan to Devin.
Ball knocked out of bounds. They're going to get a foul on Gooden. So, free throws coming here for the Pacers. They're perfect 13 of 13.
That's right back in the game. And I've always said it. The way you get back in the game, stop the clock, get to the free throw line. And they have done a good job of it.
Those coming here in this quarter. There were two Pacers scores in double figures. He's got 13 now. Siakam with 10. His 7th game with a shoulder injury. It happened opening night when he got tangled up with Shea Gilgeous-Alexander. Final 3 minutes. Dylan able to come back to the basketball. Looks for Robinson Earl on again. Booker sets a screen, drive, kick, done, hit.
Ryan Dunn is ready to shoot the ball.
Siakam, drive inside, tapped up, controlled by Phoenix.
This might be a deep shot.
Brooks on the drive, lost the handle on the way up, done inside for the recovery. travel. Couldn't quite tell if he went up to shoot and the defender distracted him, lost the ball. Either way, it results in a Phoenix turnover.
In that situation, I just grab the ball. Because you just never know. The official might think somebody touched it instead of just letting it go out of bounds.
Yeah.
You know it's a turnover, especially if you're right there. But just catch it and act like somebody hit it. You never know.
Siakam, quick pull on a three, and then Brooks sent to the deck. And they're going to get Tony Bradley. He put Brooks on the deck, and they're going to review this one. Oh, Tony Brooks is it marked? Well, wow, yeah, that will most likely generate a flagrant. As looked like he got it up around the neck.
You know, to start, that's why I love Dylan Brooks.
Achilles injury.
Oh, look,
And then Miles Turner goes rogue, if you will, as a free agent to Milwaukee. And you see the rest of the injuries that have left him short-handed all season long.
And what makes it even all the way back to Game 7 is Tyrese Halliburton was on a heater like Dylan Brooks in Game 7. And he does that. So, yeah, I mean, again, Matherin's out. He was averaging about 30 in the few games that he played to start the season. He was looking really good. Hollow was out. So, yeah, Nemhart was even out for a while. So, that's that. So, you understand how they got off to the slow start.
Book on the drive, lost the handle. Phoenix turnover. That's the fourth turnover for the Suns. Big story for the Pacers. The corner three off the mark. Back tap controlled by Indiana. Anthony Smith. No. This is not a good three-point shooting team. They are dead last at 30%. Mavericks take slight improvement in Booker with the mid-range pull-up. 7-0 Phoenix run. Matching the biggest lead of the game as Siakam will get the whistle and the foul. He's not going to get the continuation as Emily Sago looks on with Carl Lane, and that will be a personal on Dunn.
Yes, that's a great screen there. Kevin just did the rest. So they're so worried about Brooks and obviously Grayson, but Grayson got returned from the locker room yet. He did hit quad area. Devin probably feels loose and free now. They're not worried about him for a second.
This will be the 15th free throw attempt in the quarter now for the Pacers. For Loudoun, he will stay within striking distance. Siakam 22 and Dunn snatching that one away on the miss. Dunn gets his Hooker screen. Stepping 2 of the shot clock. Look at the ball fake. Laid back. Pulls from deep. No. Rebound Siakam. Siakam driving. Stumbled. Lost his balance. No call there. Denmark working on O'Neal. He'll take the mid-range. 16 now for Denmark in his 14 minutes.
They're hanging around. They're not allowing the Suns to really put their foot on them in the quarter.
Brooks probing the defense. Off balance drive with the finish and the foul. Like he was Macho Man Randy Savage.
It's nothing worse than a villain destroying you on the offense. I mean, look at that shot. I mean, he's like a ballerina.
Watching that play from Grayson last night, says, "Hey, Grace, watch this."
Yeah, 24 points in the first half.
12 of those coming here in the quarter. Made Denmark give up his dribble. Siakam spins inside. Turnover Pacers. Well, I tell you what, for a team that's coming off the back-to-back against a team that sat and watched the other play, this Suns team has got all the things that Jordan Knott talked about. The juice, the energy, the competitive fire.
That's why I kick back all the time when people talk about, oh, you played in this before.
Basketball. Booker looking for 2 for 1 and registers the three-point hit. Suns 7 of 15 from downtown. Smells like cheeseburgers. Denmark tied up. Tough contest. No. Finding a loose ball rebound. Oso's got it. Fight for it. Well, I tell you what, Oso has had himself a half. Final seconds. Booker going up. Somebody got fouled on the way up. But a great finish of the half of the Suns.
The wiring from both of the eyes travels through the brain. A third of the brain is devoted to the visual pathway, all the way back to the occipital cortex. This process is plastic. It changes over time. Kids are flexible. It's amazing. Now, if both eyes are working, everything forms fine. But what if you have one eye that doesn't see as well? Well, as the wiring is forming, the better eye starts to develop connections much stronger, and the weak eye doesn't develop those connections in the brain nearly as strong. In some ways, the eyes are competing with each other, at least on the brain scale. So, how do you treat this? You penalize a good eye. You force that, quote, lazy eye to work. That way the wiring can form into the back of the brain, and so that lazy eye can see into the future. Kids can develop amblyopia very easily if they have one eye that doesn't see well. They might have a congenital cataract. They might have one eye that's very nearsighted compared to the other eye, or farsighted. One eye may turn inwards, and so in order to keep from getting double vision, they learn to use one eye and ignore the other one. A lazy eye can easily develop into amblyopia, and if that wiring doesn't form properly, or you don't force it to form properly, you can fix the eye all you want in the future, but the eye will never see that well because the wiring never quite formed right. So amblyopia, important to pick up and treat the underlying cause and force that lazy eye to work by using patching in the other eye. Okay, next topic, leukocoria with white pupil. Now, I have never given this lecture before. It's very short. In fact, over the past 2 weeks, I've been putting this thing together. So bear with me. But I thought this might be an interesting topic, especially to this crowd, because you're probably seeing a lot of cataract surgeries, and there's a lot of little steps. And so I thought what we'd do is go through each of the little steps that we do, and this might make it a little bit easier. So what I did was created a cartoon version of an entire cataract surgery. So we'll show that. It's about 4 minutes long, and I'll be narrating the whole time. And then I'm going to show the same exact surgery, the same orientation, everything else with a live surgery, and you can kind of compare and it'll make more sense, and I'll explain things. So, the First step when doing cataract surgery is you need to make an entrance wound into the eye. And so we create a paracentesis. I was using a little knife I was burping that blood out of the eye. This is the same idea, except we're doing it in a more controlled situation. But basically a small incision into the anterior chamber. When we say anterior chamber, that's just that potential space full of fluid right under the cornea. And you want to numb the eye up. We use surface lidocaine, but we also inject lidocaine intracamerally, which just means inside the eye, through that little incision to numb the eye up, especially the iris. The iris, the colored part of the eye, is very sensitive. It's a muscle. It can hurt. This is a gel we put in the eye. It's called viscoelastic. And this gel maintains the shape of the eye. You don't want to make a big incision, your next step, and have the eye deflate on you, but the gel also protects the inner surface of the cornea as well. We now use our keratome to make our main incision. This is a much bigger blade. It makes about a 2.8 millimeter incision through the cornea, and that's where we're going to do all our work, through this little incision. Now the first step is we need to make a hole in the front of our hard candy shell from that capsule. So we do something called a capsulorhexis, which means ripping of the capsule. And I like to start with the cystotome needle to get my circle started, and then I use Utrata forceps, basically grab and create that circle in the front of that hard candy shell. That way we can get to the chocolate and the peanut layers of the cataract. This is called hydrodissection. I'm basically blowing salt solution in between the hard candy shell and the chocolate layer to kind of separate things out, because I want to be able to get the inner part of this cataract out easily. So I spin it to make sure it's nice and separated from the hard candy shell, from the capsule, and now the thing is ready to come out. And we use our phaco emulsification, vibrates very high frequency. There's many ways to get the inner part of this cataract out. This is called a divide and conquer technique, where I create two big pieces. I break the peanut into two pieces, spin it, and turn it into four pieces, and that way I can take each pie slice out one at a time, so to speak. There's many ways to do this. I'm going to show you a different way in a second. And then we basically remove each of these pieces of that peanut, of that nucleus out, nucleus removal, and one at a time. This looks very easy here, but this is actually difficult because it doesn't look quite as nice as far as the anatomy, and I'll show you what I mean. So remove all that, and you can still see some debris in there. What is that? That's leftover cortex. That chocolate is still stuck to the inner surface of the hard candy shell, and so we use irrigation aspiration to remove that chocolate, because you want to be a nice bag, or a nice capsular bag in there, a pocket somewhere you can put the new lens implant. So we inflate that pocket up with some more viscoelastic. That way it has a nice place, nice and open, so it'll be easier to slip this lens implant in. And we inject the implant. It comes folded, gets pushed into that little pocket, and slowly unfolds into place. I use my instrument to make sure that tail end goes into the right place. It unfolds inside the eye, and that's how you do it. Now, we're not quite done yet. We still have a lot of jello in the eye, a lot of gel, that viscoelastic. So we like to remove all that, and as we're removing it, you can see the little implants kind of moving a little bit, because there's some gel stuck underneath there that's coming out. And we clear that out, and the implant's in the bag, so to speak, or in the hard candy shell. And then we hydrate our wounds. You could always put sutures in, but it's easier just to use some BSS solution, inject it into those incisions. It'll swell the tissue up and keep it from leaking, and we're done. So that's how we do the cartoon cataract surgery. Let's watch a live surgery. I'm going to repeat all these steps. We'll do it again. So we're going to do our paracentesis. We're going to make our initial incision into the eye with that little knife, just like we did before. That way we can inject all of our stuff. Then we're going to inject lidocaine into the eye to numb up the iris, because the iris is a muscle in the eye. It's very sensitive, and this patent has some air bubbles in there. We'll get those out, but it will make it easier to see our next step. We're going to inject some viscoelastic. That viscoelastic protects the inner surface of the cornea from the instruments. Make sure the eye doesn't deflate when we make our big incision. And as we fill it up there, you can kind of see it pushing the air bubble out. And it fills up the eye. Of course, it's clear, hard to see, but there it is. And we'll make our main keratome incision. This is our main incision. We kind of angle it so it's three-planar, so it's a watertight wound. The reality is we just stick it in. Here is our cystotome. It's like a little needle, and that's how we make our little rip in the front of that hard candy shell, in front of the capsule, with our capsulorhexis. And I like to move a little sideways and pull it back towards me just to get things started. And then we'll get rid of that cystotome, and we'll use the forceps. And the forceps is really where the main work is done. This is our Utrata forceps, just very small forceps, and we grab the surface of that. It's very thin. It looks like a piece of cellophane or saran wrap. And you have to be careful when I'm taking my time here, because it wants to run out to the edges. And if it runs around the back of the eye, you're kind of hosed because you don't have a pocket. It's going to be very hard to put a lens in there. And so we take that very delicate tissue, and we make a complete circle with it. And this is the time when all the autoclaves have a tendency to go off and all the rooms start opening and closing right in this crucial aspect, because if this goes bad, then it makes the rest of the surgery difficult. Now, we've created our capsular rectus. Now we'll do a hydrodissection, inject some lidocaine or some VSS solution between the chocolate and that hard candy shell layer to kind of separate them. You can see a little fluid wave went behind me. That's the water kind of rushing around the back of that cataract. We'll see it again, probably in a second. There it goes. That fluid wave tells us that the water has gotten back there. Tap down a little bit on the lens, push the water out. But let's make sure it's free. We've got to make sure that the inner nucleus is free, so it's going to be easier to remove, so we spin it. And there it is. We can see it spinning inside the bag and is ready to be removed. So here is our phacoemulsification machine, and the first step is to get rid of some of the chocolate right on the surface, because that stuff's in the way. And it doesn't look like chocolate, it's clear. It's like Jell-O. And I'm not going to do a divide and conquer here, because it takes a while. I just prefer to do what we call horizontal chop. I just ram my instrument into the cataract, take my other instrument, and I just crack it into two big pieces here. So crack, and so the peanut's been cracked into two pieces, and we'll remove each of those one at a time. And I'll probably end up cracking that bigger piece a couple times just to get it out more easily. The smaller the pieces you have, the easier it is, the less energy is required. And so we've gotten all of the nucleus out, but there's still some cortex. The chocolate layer is still in there. You can see some debris on the inner surface of that bag, so we're going to go in there with our irrigation aspiration, pull those clear Jell-O pieces of chocolate out. So we want it to look nice and pretty in there. It can cause inflammation if you leave too much of it. The sub-incisional is always the hardest. I turn my instrument upside down and go behind me like that, but it's out. We'll put our lens in and put a little bit of viscoelastic in there to kind of inflate the capsular bag so there's a nice pocket for the lens to go. Otherwise, I'll have a hard time sliding in. And you can see the edges of our capsular rectus there. They're subtle, but they're there, like a circle. And we'll inject it into that bag, and I'm using an inserter that you have to kind of screw to advance it. There's plunger ones I kind of prefer, but they'll work fine. And it goes unfolded like a taco, and it unfolds like a flower inside the eye, and you can see the little edges of those little arms, those haptics. They start to slowly fold out. Sometimes I have to assist them a little bit. Static electricity wants to stick them down. And as they continue to fold out, they secure it inside that bag, and it's in the perfect location. So we're almost done. We got to get rid of that viscoelastic, that Jell-O, or that gel in the eye. And you can see the lens spinning around in there because there's viscoelastic behind it to kind of rush forward. And we hydrate our incisions with some VSS. That way they don't leak. And we'll do our keratome incision as the most crucial one, but let's do the paracentesis as well. Check the pressure at the end, so I'll push on it with a little Q-tip, make sure it seems about normal, and if the wounds are good and not leaking, then that is how we do a cataract surgery. So, we have covered a lot of things today. We've done traumatic eye injury, a little bit about cataract surgery and history, and of course how to do the surgery itself.
As they will take their biggest lead of.
Well, he was a sugar man. You know, he was Sugar Ray. I mean, he was sweet. You know, no moment or no stage was too big for him. Michael Ray puts it up and a pound and it goes. Michael, they would go in their locker room. He tell Magic, he tell Isaiah, what's your budget?
Drafted by the New York Knicks with the 4th overall pick in 1978, Richardson electrified fans with his breathtaking drives and frustrated opponents with his smothering defense.
Michael Ray was a guy who played just like I played. Every time I saw him, he went right at me.
He was quicker than everybody. He could score, he could defend. The guy was an all-star player.
After a brief stint with the Warriors, Richardson returned east and in 1984 would lead the New Jersey Nets to a shocking upset playoff win against the defending NBA champion 76ers. A two-time NBA All-Defense selection, Richardson led the league in steals 3 times and was a 4-time All-Star. But even as his star was rising, he waged a battle with substance abuse, and eventually his off-court troubles forced him to leave.
Sixth time the Morgan Convention Center, 7052, along with our Emmy Award-winning crew, our director, David Vicky, our Hughes, our producer, Brock Kraft. I got the smooth shooter, Eddie Johnson. Avery will check in with Amanda Fugrat here in a moment, but what a great way to close that first half as the Pacers got to the free throw line and ton of that second quarter, and a 13-3 finish.
Yeah, I mean, it wasn't for that. Suns was maybe 25. Because the Pacers had shot poorly, 38% from the field, only 2 of 11 from 3. But again, that free throw line can be your friend. And the Suns have to be careful here, I think, early in this third quarter.
Yeah, still waiting to get an update on Grayson Allen's availability. He went out in that second quarter, 12 minutes, 12 points. Suns bench 17-6, 4th straight game with a double-digit lead at the half, and that's the thing that really has stood out about this team, Deej. Because I know some of the detractors, if you will, have kind of said, well, look at the teams that they're beating. Look, you can only beat the teams that are on your schedule, right?
You know what? Those are the same teams that they thought the Suns would lose to. Right. Because they said the Suns might have the worst record in the West.
Yeah.
So we can't listen to those guys.
Before the third quarter gets started, let's send it over to Amanda for the BMW Coach Chat.
Coach, let's focus in on Dylan Brooks, a new career high in a first half for him with 24 points. He's feeling really aggressive, finding ways to score. How are you seeing him take on that load?
Yeah, he's came out with a lot of pop, giving us a bunch of energy. I think we found him early in the game on some catch and shoots, and it's kind of been carrying that over through the quarters.
No Mark Williams tonight, but you have Oso. How are you seeing him kind of fill some of that void out there defensively and what he's been able to do, 5 rebounds?
Yeah, for him just being switchable, being able to guard multiple positions, and then also being that extra ball handler both on the floor.
John, thank you.
Yeah, thank you, Coach. Thank you, Amanda. And as that energy wraps up, we get word that Grayson Allen with a right quad contusion and will not return. So the Charlie Gillespie who will start this third quarter. On with Dylan Brooks, Royce O'Neal, Rick Richards, and Devin Booker. This is 24 points in 17 minutes. Booker with 17, driving right at Naismith. He'll get right to the lane, and that is one of his favorite and most successful shots.
Well, that's because Kobe was his favorite player, and that's a Kobe shot right there.
Naismith working off the screen, gets it out to Nembhard. Then they're scoring a tackle with 16 in the first half. Naismith able to get it up off the glass. Continuation. Yes, 3-point opportunity here. Aaron Naismith 18 minutes in that first half. Just turned 26.
Yeah. Feels like it's been around a long time.
Right?
Yeah. But you love this game. This guy is relentless, man. I mean, he does not back down. He does not give up. He has really evolved into a really good offensive player.
Struggled to start the season, but in the first 5 games in November, 21 points per game. Shot the ball really well, but so far tonight, 8 points. 2 of 7 from the field. Here's Richard way outside. Getting into the hands of Leslie. Fella able to get Nimhard back on his heels. On the drive and kick, sets up Brooks for the corner. Nimhard with the rebound. Quick outlet up the court out of Neesmith. Neesmith on the drive. Wow, just crazy shot off near the top of the backboard.
There's no way he meant to do that.
Well, they're going to get O'Neal for a foul.
They did turn his shoulder. They turned his shoulder. And you know, and people say, well, why did he turn his shoulder? Because he was protecting his shoulder. Like, that's the difference. And so when you're coming off a screen like that, right?
Just subtly you see that.
Yeah, but you're really protecting yourself more so than actually trying to be slick.
Nimhard walking into the three-point shot. Can't get it. O'Neal with the rebound. Booker. Quick drive down the floor. Kicks it out to O'Neal. Squares, fires, and hits. First points of the night.
When he gets the opportunity, look what happens.
And Gillespie in the backcourt nearly had the steal. Roy said, well, looks like I'm going to have to take over. As Dick Richards says, the office is closed. Rising high, and Richards with the block.
And Neesmith, as I said, he tried to find a poster.
Wow.
And Nick Richards said, not on this watch.
Bringing that big energy. And Tony Bradley getting acquainted with Dylan Brooks again. That is a spectacular block.
Maybe give you a credit, Neesmith, for trying it.
Gillespie drawn the attention of the defender, Nimhard, off the Booker. Pass to left out of bounds, and 8 on the shot clock.
Yeah, and when Devin goes to that defender like that, it's really hard to get the ball over the top, right? So he's got to kind of go at him there, jump a little higher if he's going to get it there, or kind of veer off to the side real quickly, and that'll give Colin that good open shot.
Richards comes out high to meet it. Puts it back in the hands of Booker. Deep three on the way. Back iron, no. Siakam trying to get on track with the 11 first half points. He and Dylan Brooks too. Got mixed up a few times, and Brooks not happy with that call. Felt like he got pulled by Siakam. He's wanting the coaching staff to take a look, see if it's worthy of a. Dylan is adamant about it. Yeah, you could. Got a pretty good argument there. Siakam 6 of 7 from the free throw line, 12 points. Dylan's got to be careful. He's got 1 technical foul already.
Yeah, they're going to be very weak. You know, he's upset. And they don't know if they blew the call. See, that's why I love officials. People can try to criticize NBA officials, but these are the best officials in the world in regards to officiating these high-octane athletes. And, you know, they probably, you know, they maybe thought they missed the call. But that's why they're allowing them to look down.
Booker out of the way. Neesmith hits it back.
He kind of hurt himself on that one. That is not good.
Feeding into the corner, Gillespie finds the open shooter O'Neal from the corner. Yeah, Neesmith is.
Yeah, that's not good. He did a split. You know, don't break your wrist, young man.
He is dragging a lot of pain over there, and that's the last thing his Pacers team needs.
Yeah, you can tell the way he fell.
Yeah.
I mean, that's a groin or claw is not good.
Set him out on the floor.
The National Basketball Association Phoenix Suns and Mortgage Matchup Center seek to foster a safe and enjoyable sports and entertainment experience.
He's got really good at that. You know, good where he's just almost standing straight up, dribbling and turning and getting to the rim.
On the cut, pass inside of Siakam, quick turn. That's four.
They got lucky off a couple of shots on the backboard. I don't know if Siakam was trying to bang that in.
Brooks whistle for the over and back.
No argument there.
Yeah.
So again, look, this is a 14-point game.
About a year, right?
20 minutes left in this game.
Yeah.
And the Suns have to reconnect here.
So we saw the Pacers in that second quarter kind of muck things up back to the free throw line 15 times. And were able to climb back within 7. The pass inside Gillespie couldn't quite get there in time of the steal. No Grayson Allen as he is sidelined the rest of the night with a right quad contusion. Quick inbound, Shepard gets them up for the corner.
The wrong guy to be leading left over. You know, he's inconsistent. He's a tremendous shooter, but you give him a chance to knock one down, all of a sudden he can't miss.
At 21% on the season. That's the second lowest three-point percentage in the league. Gillespie finds Brooks. Brooks tied up. Bubbles away inside. Drops it off to Richards. And he gets Tomahawk there by Siakam. The Warriors are going to give him free pass to the basket. Great recognition that time by Gillett.
They do have to, like, straighten up here in regards to knowing it's going to be physical, but also defensively. Gang rebounding. You got a desperate team now. It's not shooting the ball well, which means they're going to crash the offensive glass. And that rebound will turn into a layup at the other end.
Check in here for Kyle Gillespie. Points tonight for Nick. He's not credited with any rebounds, but he's got good jobs of kind of shielding and boxing out, providing rebounding opportunities for his teammates. As Newmark getting into Dunn. That'll be the third team foul already here for Suns. 7:25 to go.
You know, when you don't shoot the ball well, what do? You try to get to the free throw line. You try to get closer. And the Suns right now are playing a team that look like 90% trying to get closer than where they are when you catch them.
And a desperate team at that, looking for their first road win of the season. As we get a message from our friends at Jack in the Box.
The best gravy burger in fast food with more beef than a Big Mac. Keep up, bro. Welcome to Jack in the Box.
1 and 2, quick outlet up the court out of Brooks. On the drive, drops it up to Richards inside. He gets tripped up there towards the basket. Yeah, taking a moment to collect himself.
Man, I used to jump up like that. Nick Richards, he jumps up, man, and then he, like, elevates after, gets halfway up.
Right.
I used to do that. You know, it's just certain things you see that just like,
Right.
man, they should just pop up, man, without even putting my, falling off the feet down. I just pop up. Now I have to be pulled up.
Let's swing it down to Amanda.
Thanks, K-Ray. I just got word Aaron Smith will not be returning for tonight's game. He's listed out with left soreness.
Thank you.
So that's good. Yeah.
Lead Thornton. Denmark with a jump stop. Booker fights through the traffic for the rebound. Goes behind the back, swings it across to O'Neal. Will settle in here. Half-court offense. Going inside.
Yeah, Nick Richards has to get better at everything is with two hands. That particular shot, you put your body into the guy and you just lay it up. Stick your arm out and lay it up with your right hand. Now watch what he does. He catches it and now he wants to go up to two. That's a one-handed shot because you know the defender is coming. So you try to get it over to the right.
And the Pacers are going to call a timeout to challenge, apparently, our first green light special of the night. 80-67, Suns in front.
It's that time of the night already, brought to you by EOS Fitness and Studio B Smiles, the official cosmetic dentist of your Phoenix Suns. Please welcome to the court the best dance team in the NBA, your Suns Dancers!
Cataract surgery is one of the miracles of modern medicine. With a 10-minute procedure, we have the ability to take someone who was previously blind to seeing perfectly again the next day. But despite the incredible advancements we've made in surgical technique and technology, there are still patients who suffer from poor outcomes after surgery. You may have heard, maybe from a friend or family member who had the surgery, and unfortunately, maybe they've been dealing with problems of poor vision ever since their surgery. So in this video, I'm going to go through the top 6 mistakes that patients and their surgeons want to avoid so that you can enjoy a successful outcome after cataract surgery with comfortable, clear vision. By the way, I'm Dr. Michael Chua. I'm a board-certified ophthalmologist, and I make videos to help you see better, look better, and feel better too. The first mistake you want to avoid when planning cataract surgery is not addressing uncontrolled diabetes. A recent research study from Italy, which looked at the medical history of patients receiving cataract surgery, found that 20.4% of patients had underlying diabetes. And if we look at the latest reports from the CDC, we see that the rate of diabetes in patients over 65, which is the most common age group for cataract surgery, is 29.2%. These studies tell us that a significant portion of our patients who are receiving cataract surgery also have diabetes. And this is very important because we know that patients with diabetes and uncontrolled blood sugars have a significantly higher risk of having complications with cataract surgery. My experience and countless research articles back this up. We see that patients with diabetes have delayed wound healing, increased risk of little scratches in the cornea or epithelial defects after surgery, higher risk of post-operative infection or endophthalmitis, higher risk of posterior capsular opacification, or basically clotting of the capsule of the bag that we implant the new lens into, and also a significantly higher risk of developing macular edema or swelling of the retina, which will affect your vision. So what can you and your ophthalmologist do to help mitigate these risks? Well, we already talked about controlling your blood sugars, but also your surgeon will want to consider using not only a steroid eye drop, but also a non-steroidal anti-inflammatory drug or NSAID eye drop, such as bromfenac or ketorolac after surgery. This is because using a combination of steroid and NSAID eye drops have been shown to significantly decrease the rate of post-operative macular edema in patients with diabetes. Your ophthalmologist will also want to consider injecting some antibiotics into the eye at the end of surgery, as this has been shown to significantly decrease the rate of post-operative infection or endophthalmitis. Okay, the next mistake we want to avoid when going into cataract surgery is not adequately managing dry eye syndrome. A meta-analysis published in 2022, which looked at all the previous studies investigating dry eye after cataract surgery, found that 37.4% of patients who did not have a previous history of dry eye, 37.4% of patients went on to develop dry eye disease after cataract surgery. Now, fortunately, for most patients, these dry eye symptoms are only temporary. But if we have patients who already have a history of dry eye syndrome before surgery, we know that they are very likely to suffer worsened symptoms during the post-operative healing period. So we want to make sure we tune up the dry corneal surface as much as possible prior to surgery to help decrease the severity of symptoms. I've gotten into several deep dives into different dry eye treatment options in previous videos, but treatment will likely include some combination of lubricating eye drops, perhaps prescription eye drops, warm compress, punctal plugs, or other procedures to help moisturize your cornea. The other important consideration of dry eye and cataract surgery is that if you have dry eyes during your preoperative planning, this can affect the measurements we take to decide which lens to put into your eye during surgery. As your ophthalmologist is planning your surgery, we take precise measurements of your eye, including the curvature or shape of your cornea and the length of your eye, so we can determine exactly what power lens we need to implant into your eye to help you see as clearly as possible after surgery. If your corneal surface is very dry during these measurements, then the measurements will be inaccurate, and this can cause your ophthalmologist to choose a lens that isn't quite right for you. So your ophthalmologist will need to diagnose your dry eye syndrome during preoperative planning and treat it aggressively. Then repeat your eye measurements perhaps several times to help ensure that they can choose the best lens for you. Okay, the next mistake you or your ophthalmologist will want to avoid before cataract surgery is missing other eye conditions such as glaucoma, macular degeneration, or amblyopia, which will affect your vision even after cataract surgery. During your cataract evaluation, your ophthalmologist will perform a comprehensive review. They'll check on the health of your retina and your optic nerve, And the goal is to uncover any other eye diseases that can be affecting the vision. At our practice, for example, we perform OCT retinal scans as well as wide-field retina imaging on all of our cataract surgery patients to help us catch any underlying eye conditions. There are other conditions, such as keratoconus, which is basically steepening of the cornea on the front surface of the eye. So the shape is more like a cone rather than round like a ball. This will affect your intraocular lens calculations, so we'll want to look out for that condition. Another important condition we screen for during the preoperative evaluation is called Fuchs dystrophy, or basically a disease of the inner lining or the endothelium of the cornea. And if you have this condition, this increases the risk of corneal swelling or even needing a corneal transplant after cataract surgery. So that's a condition we don't want to miss. The other important reason to screen for all of these other eye conditions is because it will affect which types of lenses you'll be a candidate for during surgery. For example, patients with more advanced glaucoma, macular degeneration, or diabetic retinopathy usually aren't good candidates for premium lenses such as multifocal or extended depth of focus lenses because their visual outcomes may not be so good even after surgery. So all this to say that a comprehensive, thorough preoperative evaluation is super important for your cataract surgery. Okay, the next mistake I see with cataract surgery is incorrect expectations. Now, the lens and surgical technology we have for cataract surgery is incredible, and we can give patients wonderful vision with surgery, but sometimes patients may be expecting to have vision like when they were in their 20s. Perfect vision for distance, intermediate, and near, without any drawbacks or side effects. Unfortunately, we don't have the technology to give patients absolutely perfect vision like when we were all younger. And so it's up to us ophthalmologists to let patients know what to expect in terms of vision after surgery. For example, if a patient is receiving a basic monofocal lens with cataract surgery, patients will usually still need to wear glasses even after surgery. And even if patients receive the latest and greatest lenses, maybe extended depth of focus lenses like the Symphony or Vivity, or a trifocal lens like the Panoptics, there still may be some times where patients may need to use reading glasses. For example, in darker environments, trying to read small print up close. Another particular situation where patients may need to temper their expectations with cataract surgery is if they've had LASIK in the past. Now, after we take measurements of the eye to plan for cataract surgery, we usually use calculators which assume a normal corneal shape. But in patients with a history of LASIK, during LASIK, a laser was used to alter the shape of the cornea. And because the shape of the cornea has been altered with LASIK surgery, the typical formulas we use for lens calculations are no longer accurate. So we have specific formulas that help us to account for a patient's history of LASIK. But research shows us that even with the latest formulas, patients who have a history of LASIK have a slightly more unpredictable outcome in terms of residual glasses prescription after surgery. Okay. The next important mistake to avoid with cataract surgery is not following post-operative instructions. So, cataract surgery went smoothly, everything's looking good, but we're not out of the woods quite yet. Every doctor will vary in terms of what post-op medications they prescribe, but usually we will prescribe some combination of antibiotic eye drops, steroid eye drops, and non-steroidal anti-inflammatory eye drops after surgery. These drops are important for the healing process. For example, steroid and anti-inflammatory eye drops help treat and prevent inflammation in the eye after surgery, and they help to prevent swelling in the retina or macular edema after surgery. There have been several times after surgery where a patient comes back a week or two later with a painful red eye and sensitivity to light, and basically inflammation in their eye after surgery. I ask them if they've been using their post-op drops, and they'll say, no, I didn't really feel like I needed them. But once I get them back on their eye drops, their inflammation and symptoms improve quickly. The other important set of instructions to follow after surgery is not to do any heavy lifting or anything too strenuous for the first couple of weeks after surgery. This is because the incision from surgery still needs time to heal, and we want your new implanted lens to stay exactly where we placed it during surgery. I've heard stories from several surgeons of patients maybe playing golf or tennis a day or two after their cataract surgery, and as the patient strains
Golf after cataract surgery.
they can inadvertently cause a buildup of pressure inside the eye and cause the iris to burst out of the cataract surgery incision. This is obviously a complication we want to avoid, as these patients have a significantly increased risk of infection and may need a trip back to the operator. I've heard stories from several surgeons of patients maybe playing golf or tennis a day or two after their cataract surgery, And as the patients strain with a strong swing of a racket or golf club, they can inadvertently cause a buildup of pressure inside the eye and cause the iris to burst out of the cataract surgery incision. This is obviously a complication we want to avoid, as these patients have a significantly increased risk of infection and may need a trip back to the operating room to put everything back into place. So, after cataract surgery, remember to follow your surgeon's instructions and take it easy for those first few weeks after surgery. Before we discuss the next mistake you want to avoid with cataract surgery, I wanted to quickly tell you about my optimized newsletter. If you want science-backed tips on how to protect your vision and health delivered straight to your inbox, you can sign up for my optimized newsletter at michaelchuamd.com. Okay, the last mistake I'll talk about when it comes to cataract surgery is waiting too long for surgery. Now, in most cases, cataract surgery is an elective surgery, meaning you and your doctor decide together when to proceed with surgery. Usually, we wait for cataracts to be visually significant, meaning that the cataracts are causing vision problems that are affecting the activities you do every day, like reading, driving, watching TV, or looking at your cell phone. And most of the time, there really is no rush, no pressure to get the surgery until the patient is ready. Having said that, there is an ideal window of time to get cataract surgery in terms of safety. We usually grade cataracts grade 1 through grade 4, with grade 1 being mild, grade 2 being mild to moderate, grade 3 being moderate to severe, and grade 4 being severe. Usually, the best time to get cataract surgery is when the cataract is grade 2 to 3. This is when the cataract is dense and cloudy enough to be affecting your vision, so you would notice a significant benefit to your vision after surgery. But when we venture into surgery on grade 4 cataracts, since the lens is denser, thicker, and cloudier, surgery on these dense cataracts usually requires a bit more manipulation in the eye and can increase the risk of complications, such as corneal or retinal edema or swelling, or maybe damage to the capsule, which is the membrane that holds the lens in place. And so when we start getting into that grade 2.5, grade 3, grade 3.5 territory, we do want to consider cataract surgery before the cataract progresses to a severe grade 4 cataract. During your appointment with your ophthalmologist, go ahead and ask them, what's the grade of my cataract? If you're a little bit hesitant towards surgery, feel free to ask, how much longer can I safely wait for surgery? These are good questions to have prepared going into your cataract surgery consultation. Okay, so that was a whirlwind review of some of the most important mistakes to avoid when considering cataract surgery. In summary, some of the things we want to remember when considering cataract surgery are controlling blood sugars and diabetes preoperatively, as uncontrolled diabetes can increase the risk of complications after surgery. Manage dry eye disease before surgery, since we know that it's very common for patients to develop or to have worsened dry eye symptoms after surgery. Although in the majority of cases, this dryness improves with time. Receive a thorough evaluation to rule out any other ocular conditions, such as macular degeneration or glaucoma, as these will affect your vision even after surgery. And these conditions will influence which intraocular lens you may or may not be a candidate to receive during surgery. Have realistic expectations about what kind of vision can be achieved after surgery, particularly if you're thinking about premium multifocal or extended depth of focus lenses, or if you've had a history of LASIK. Our technology is incredible, but unfortunately, there's nothing that can bring back the vision from our 20s. Follow post-operative instructions, including using your post-operative eye drops and avoiding strenuous activities for the first couple of weeks after surgery. And lastly, to have a good, detailed conversation with your surgeon about when is the best time to safely proceed with surgery. Okay, I hope this review was useful to you. If you live in the Los Angeles, Orange County, or Inland Empire area and want to get checked for cataracts, feel free to visit our website or give our phone number a call to make an appointment today. And don't forget to subscribe to the channel to get all the latest updates. And if you made it this far into the video, that probably means you're really interested in learning more about cataract surgery. You can watch my video here to learn everything you need to know about cataract surgery and what to expect with the procedure. I'm Dr. Michael Chua with Pointed Hills Eye Care. See you next time.
Can I call this done now?
On the turn, won't get it done. Easy high for the rebound. Good defense that time by Isaiah Livers. Booker pulls for three. Yes, sir! Well, that is 9 games now against Eastern Conference opponents. And Book cooking for 30 plus. Shepherd on the drive. Tough. Running right hand hook. Another rebound for Booker. Feeding Oso. Goes inside. Why not? Book with a half-court dime delivery.
Great pass. And also running the floor. And all he had to do was just lob it up there. If he had thrown it high enough, he probably would have taken it in the air and slammed it home.
It's a free throw with the long rebound. Tap back to it. Booker puts it past inside. Also, that's one way to get the three-point play. Making it 4-point play. 16-0 won by the Suns. Just after the Pacers had cut it to single digits. Nembhard on the drive. Gets tangled up.
Sure said he's grabbing it, right? So don't give him something to grab. Keep your hands up high and make him make a tough shot. If you put your hands down low, he's not even looking at the rim. He's looking at a way to get his arms up under yours. Yeah, Shepard's in no man's land. I mean, you get down a running start at you, what are you going to do?
Bruce said, yeah. Nembhard at the line. .21 for Nembhard, who's got his own version of the Book Ones tonight. One of several players across the league that are wearing the Book shoes. We got about a half dozen, especially made last year. They're running to the finals. That one gets kicked out of bounds. Shout out to Mr. Tony for dropping the knowledge for me.
Where's your book shoes?
In the closet. In the storage box. I wore them last night. Oh, did you? Oh, that's right. You weren't there. Siakam, great on-ball defense by Doug. And then avoids the foul, but Siakam still standing.